Welcome to the MS-Perspektive podcast, Perspective with a K as I'm German. I'm Nele van Horsten, MS patient, patient advocate and author. I'm bringing you interviews, inspiration and information about living with multiple sclerosis and show you ways how you can positively influence the disease and make the best out of your diagnosis. On ms-perspektive.com you will find the show notes, 11 free tips as a PDF and lots of other information. And now the show begins. Thanks for tuning in again and welcome to episode number 78, another one about immunotherapies. This time it's all about Cladribine, which is known as Mavenclad, Leustat or Litak, for highly active MS. Cladribine, known as Mavenclad, Leustat or Litak, is an immunotherapy from the field of immunosuppressants that is used to treat highly active multiple sclerosis. It belongs to the class of disease-modifying therapies, DMTs, which use depletion to target the immune system in order to prevent the progression of the disease. Find out more about the principles of induction therapies, how Cladribine works, how effective it is, and the potential risks associated with it. You will learn about the role of Cladribine in MS therapy, its different forms, and what patients should know when considering this treatment, particularly with regard to pregnancy, breastfeeding, and long-term health monitoring. Please remember that I can only provide an overview here. Your neurologist and your MS nurse should advise you in detail about the right therapy for you. This is because they know your general state of health, and you should also talk about your goals, wishes, fears, and preferences so that these can be taken into account. Let's start with the general information. To get a good overview of the major topic of therapy decisions, I recommend that you first listen to episode number 58, Immunotherapy in MS, a guide to efficacy and choice with Professor Dr. Tjalf Siemsen. There you will find out why you can only compare the various disease-modifying drugs to a limited extent, why it is important to start an effective therapy quickly, why MRI and other examinations are important for assessing progression and provide information about effectiveness, why therapies should be changed as little as possible, but of course if they are not effective enough, why in most cases it is better to start with a highly effective therapy and only switch to a lower category at an advanced age, why in the case of highly active MS it may be more important to start immunotherapy quickly and tackle rehabilitation as a second step, why generics and biosimilars are being used more and more and which approval requirements they have to fulfill, why the risks and side effects of a therapy must be differentiated into unpleasant side effects at the start of therapy and rare possible risks, and these must be set in relation to the usually irreversible effects of untreated MS in the long term, why it is important to honestly discuss your opinion, wishes, goals, and fears with your neurologist in order to make treatment decisions together that both sides can agree on, why it is advantageous to be cared for by MS specialists and to stay informed yourself in order to benefit from new findings and treatment options, and why you should contribute to a favorable prognosis with your own healthy lifestyle. Another general note. The approval studies for the individual drugs were carried out at very different times. 30 years ago, you had to be more severely affected or more advanced in the course of the disease to receive a reliable diagnosis of multiple sclerosis. Less severely affected people were probably not diagnosed or not diagnosed at first. With ever-improving examination methods such as MRI, even small lesions in the central nervous system can now be seen better. Furthermore, 30 years ago it was not yet known that neuromyelitis optica spectrum diseases, NMOSD for short, and MOGAD are separate diseases that require their own therapies and sometimes even react negatively to MS medication. They were previously thought to be multiple sclerosis, and MS therapies did not alleviate the disease activity. How is Cladribine, Mavenclad, Leustat, Litak, classified in immunotherapies? There are currently 3 different therapeutic approaches for the preventive, i.e. disease-modifying therapy, short DMT, of multiple sclerosis. The most unspecific is immunomodulation. Migration inhibition already narrows the pathway, and the most specific is a depletion of immune cells, which also includes Cladribine, so Mavenclad, Leustat, Litak. The DMTs are listed in alphabetic order. Number 1. Immunomodulation. The therapies weaken the immune system. They have a very broad effect via various factors, e.g. on Th1, T17, Th2, Treg, and antigen presentation, as well as on different signaling pathways and possibly via other mechanisms. They attempt to shift the milieu from inflammatory to non-inflammatory. The following ones belong to it: dimethyl fumarate with Tecfidera and generics and diroximel fumarate with Vumerity, Cladribine acetate with Copaxone, Glyft and Brabio, interferon beta with interferon beta 1a with Avonex and Rebif, interferon beta 1b with Betaferon and Extavia, and PEG interferon beta 1a with Plagridi. And last but not least, teriflunomide with Aubagio. Number 2. Migration inhibition. The migration of certain immune cells is inhibited. 2 belong to it: natalizumab with Tysabri and Churuku, and the S1P modulators with fingolimod, known as Gilenya, ozalimod, known as Zeposia, ponesimod, known as Ponbury, and siponimod, known as Mayzent. And there's category number 3, the cell depletion, where developing immune cells die off. The depletion of T cells, B cells, natural killer cells, and monocytes happens in alemtuzumab, known as Lemtrada or Kempas. T and B cell depletion happens in Cladribine, known as Mavenclad, Leustat, Litak. And B cell depletion is ocrelizumab with Ocrevus, ofatumumab with Kesimpta and Bonspree, rituximab with Mabthera and Rituxan, and ublituximab with Briumvi. What is Cladribine, Mavenclad, Leustat, Litak approved for? Cladribine is approved for the treatment of highly active relapsing forms of MS in adults. A detailed benefit-risk assessment should be carried out, which can be based on the existing pivotal studies of Clarity, Clarity Extension, Oracle MS, and Onward. Against the background of these study data, Cladribine can be used in the following patient groups: patients who have high disease activity during therapy with a disease-modifying drug, i.e. in the previous year, who have suffered at least one relapse during disease-modifying therapy, and who have had at least 92 hyperintense lesions or at least one gadolinium-enhancing lesion on brain MRI. Patients with 2 or more relapses in the last year, regardless of whether they were treated with disease-modifying therapy or not. Different information or recommendations are possible from country to country. What is the situation for special patient groups? Let's start with children and teenagers. Due to the risk of cancer, Cladribine, Mavenclad, Leustat, Litak, is not recommended in MS patients under 18 years of age. There is no data on safety or efficacy in pediatric patients. Pregnancy and breastfeeding. What is the recommendation of the European EMA and American Regulatory Authority FDA? Women of childbearing age should use effective contraception during treatment with Cladribine, Mavenclad, Leustat, Litak. A negative pregnancy test must be available before each treatment cycle. If possible, contraception should be used with both a contraceptive and a barrier method, such as a condom. The interval between the last dose of Cladribine should be at least 6 months. This also applies to men, as an increased rate of miscarriages and malformations was observed in animal studies, regardless of whether the mother or father were exposed to the active substance. Should a pregnancy nevertheless occur during treatment or with an interval of less than 6 months, treatment should be discontinued immediately and intensified diagnostic carried out during pregnancy. Cladribine should not be taken while breastfeeding. The recommendation of the DMSKW, the German MS Fertility Register, is as following. In the clinical trials of Cladribine, Mavenclad, there were only a few pregnancies, most of which were deliberately terminated. The number of miscarriages was in the line with the normal miscarriage rate that occurs in the general population. 3 children were born healthy and there were no malformations. The few other children born after the approval of Cladribine were also healthy. Our registry documented 62 pregnancies in which the mothers had taken Cladribine at various intervals prior to pregnancy. Of these, 46 babies were born healthy. 2 babies had low birth weight, taking Cladribine more than 6 months before pregnancy, and 1 baby had a heart defect, which is also common in the general population. The mother had taken Cladribine 66 days before pregnancy. Cladribine can pass into breast milk. Initial data from the registry shows that in one patient who took Cladribine in the first and second week of treatment, only a small amount, about 3% of the dose, passed into breast milk. However, as Cladribine is rapidly broken down in the body, no active substance could be detected in breast milk 48 hours after the last dose. As Cladribine remains effective for longer, it could theoretically offer advantages when planning a pregnancy. However, if you become pregnant during treatment or within 6 months of your last dose of Cladribine, please contact your doctor immediately for appropriate advice. If you become pregnant during a treatment cycle, treatment must be stopped right away. You must not breastfeed while taking Cladribine. However, as the drug is rapidly broken down, it is safe to resume breastfeeding 1 week after the last dose. Breastfeeding is not permitted before then. Who should avoid Cladribine, Mavenclad, Leustat or Litak? People with hypersensitivity to the substance or one of the other ingredients. People with acute and chronically active infections such as HIV infection, tuberculosis, hepatitis B and hepatitis C, immunodeficient patients, patients with moderate or severe kidney disease, patients with moderate or severe liver disease, vaccination with a live vaccine in the previous 4 to 6 weeks, e.g. vaccination against varicella zoster virus, VZV, typhoid, yellow fever, etc., pregnancy or breastfeeding. A relative contraindication exists for patients with a high susceptibility to infection, e.g. pressure sores on the skin, aspiration tendency, frequent urinary tract infections or respiratory infections. Patients with a history of malignant diseases, fructose intolerance as a Cladribine tablet contains sorbitol, and children under 18 years of age. No data are available on safety and efficacy in pediatric MS. How does Cladribine, Mavenclad, Leustat and Litak work? Cladribine reduces the pro-inflammatory subset of immune cells and increases the regulatory cells. It specifically reduces certain types of immune cells, known as T and B cells, both dividing and dormant. The drug works by causing the cells to die. Among other things, it blocks an important enzyme in dividing cells. In resting cells, Cladribine causes a rapid loss of energy, which leads to the death of the cell. Cladribine belongs to the induction therapies and is an immunosuppressant, which means that it acts quickly after ingestion and has a long-term effect on the immune system with only a short duration of administration. A new 4-year therapy cycle can be considered from year 5 onwards. However, real-world data on this is still lacking. How is it taken? Let's start with Mavenclad, as this is the normal one, which people take. Cladribine is administered orally as tablets at a total dose of 3.5 milligram per kilogram body weight in a total of 4 treatment cycles. A treatment cycle comprises 1 or 2 tablets per day for 4 or 5 days. The dose must be adjusted according to weight. The following dosage regimen of Cladribine has been approved by the EMA for the treatment of multiple sclerosis. In the first year of treatment, Cladribine is administered orally at a dose of 1.75 milligram per kilogram body weight. In the second year, oral administration of Cladribine is repeated at a dose of 1.75 milligram per kilogram body weight. The first 2 treatments are given in the weeks 1 and 5, and the 2 further treatments in weeks 53 and 57. These 4 weeks of tablet intake should ideally cover for 4 years of treatment. The tablets should be taken without chewing at the same time each day of the treatment cycle. You can take the tablets independently of meals. It is recommended that you take them 3 hours apart from other medicines, as an ingredient in the Cladribine tablets may interact with other active substances. The amount of Cladribine you need to take is calculated based on your body weight. The manufacturer provides tables to help you determine the dosage quickly and easily. You take either 1 or 2 tablets per day. If you need to take 2 tablets, you should take both at the same time as 1 dose. The maximum amount that can be taken over 2 years is 40 tablets of 10 milligrams each. For some patients, a 3rd or 4th course of Cladribine may be required. Let's just talk slightly about Leustat and Litak. Leustat and Litak are non-oral forms of Cladribine that might be used off-label for treating MS. They are given by infusion or injection. These forms of Cladribine are expected to work similarly to the tablets and may have similar side effects, but this hasn't been fully proven yet. How effective is Cladribine, Mavenclad, Leustat, Litak? Gavin Giovannoni, an MS expert from the UK, has graded his ML certificates on a scale of 1 to 10, with 1 being low efficacy and 10 being maximum efficacy. In his estimation, Cladribine scores 6 for preventing relapses and 8 for avoiding long-term disability. In the 2-year pivotal study, Cladribine was compared to the placebo and reduced relapses by 58% and slowed disability worsening by 33%. In other words, you can also look at 100 patients. 61 of these patients remain relapse-free even on placebo. In the Cladribine group, a further 19 patients remained relapse-free. Looking at the same 100 patients, 79 remained at the same level of disability as measured by the EDSS, the Expanded Disability Status Scale, during the pivotal trial period, including the placebo group. 7 people in the placebo group deteriorated who remained stable on Cladribine. The Clarity and Clarity Extension trials showed no evidence of disease activity in 3 categories, which is known as NIDA-3. In years 3 and 4, for 46% of people who first received a placebo and then Cladribine, and 48% of those who had taken Cladribine from the start. NIDA-3 means that there were no relapses, no worsening of disability, and no signs of disease activity on brain MRI scans. Let's talk about the risks and side effects of Cladribine, Mavenclad, Leustat, and Litak. The Clarity Extension, Oracle MS, and Onward studies formed the basis for the approval of Cladribine. The following side effects occur frequently. More than 1 in 4 patients experience lymphopenia, a low white blood cell count that may persist for an extended period of time. This can lead to the second cycle of Cladribine having to be postponed in weeks 43 and 47, or sometimes not being given at all. The most typical side effects after taking Cladribine are skin reactions and, rarely, thinning hair and hair loss. There is an increased risk of herpes infections that cause shingles and cold sores. Safety precautions and lab parameters. The clinical neurological check-up must be carried out quarterly. Before each treatment cycle with Cladribine, your doctor should review your medical history and perform a clinical examination to check for any possible reasons why you shouldn't take the medication. The basic laboratory program. Routine laboratory parameters are blood count plus differential blood count that must be checked before each treatment cycle with Cladribine. A precise typing of the white blood cells can also be carried out if this appears useful. Checks should then be carried out every 2 or 3 months. If the lymphocyte count falls below a critical level, treatment should be suspended in the 2nd year, and treatment should only be continued once the values have normalized. If normalization takes longer than 6 months, Cladribine should no longer be given. If white blood cells counts are low, closer monitoring should be carried out and herpes prophylaxis should be considered if necessary. The liver and kidney values must be checked before each treatment cycle with Cladribine and then every 2 to 3 months over the entire treatment period. An infection must be ruled out before each Cladribine treatment cycle. If signs of a clinical relevant infection occur during Cladribine therapy, anti-infective therapy should be initiated. The administration of Cladribine should be interrupted or postponed until the infection is completely cured. A negative pregnancy test must be available before each Cladribine treatment cycle. Let's move on to the radiological monitoring. An MRI of the brain and possibly also of the spinal cord should be performed once a year to assess the success of the treatment and to detect possible complications of the therapy that are relevant for the differential diagnosis. Contrast agents are only necessary if there are indications of a worsening of the disease or if there is no standardized initial MRI. Cancer screening examinations. Since Cladribine can temporarily weaken the immune system, patients should follow standard cancer screening guidelines and go to the recommended checkups. Additionally, blood tests should be done for at least 2 years after the last dose of Cladribine to monitor your health. You do not need to worry about this. It will be checked for you. However, please take the test seriously and make up for them if you are unable to keep an appointment, and don't skip them altogether. On the MS selfie card mentioned earlier, the side effects are rated on a scale from 1 for few or rare to 10 for many or frequent as follows. Regular side effects at 2. Long-term side effects at 1. Cancer risk at 5. Cladribine receives the following rating in the MS selfie card overview of the effects of therapy. Clinical visits, minimal. Family planning, short-term incompatible. Vaccinations, good response. And vaccinations is something I want to talk about at the end. The efficacy of vaccinations may be limited during and after Cladribine. If necessary, the success of the vaccination should be checked by means of titer control. Live vaccines should be avoided and only administered after a thorough risk-benefit assessment. All other vaccinations are permitted during treatment with Cladribine. Vaccinations against herpes zoster, which leads to shingles, is recommended for patients with immunotherapy from the age of 50. In this case, vaccination with the inactivated Shingrix vaccine is recommended. Finally, I want to talk about my sources. I used the following ones to create the content. The lecture on Cladribine by Professor Dr. Johann Sellner as part of the Master's Program Multiple Sclerosis Management. The quality manual of the German KKNMS on Cladribine Mavenclad. The MS Selfie Info Cards by Professor Dr. Gavin Giovannoni. The German Multiple Sclerosis and Fertility Registry, DMSKW, and the German DSIMS information on Cladribine. One final note. Please remember there is no one great medication that helps everyone, but it must always be weighed up what suits a particular person best. Other illnesses, personal goals and preferences must also be taken into account. Your neurologist and MS nurse are the right persons to talk to and can make individual recommendations. This podcast is for information purposes only and does not constitute a recommendation. What helps one person may not help another. I hope that together with your neurologist and MS nurse you will quickly find the right immunotherapy for you, and that you can lead a fulfilled, happy and self-determined life with MS, supported by a healthy lifestyle and a dose of fortune. I hope you liked the content and that it helps you to make decisions on your immunotherapy. By the way, you may also want to listen to the following episodes that have been published before. Number 61, dimethyl fumarate, Tecfidera and diroximel fumarate, Vomerity. Podcast number 65, glatiramer acetate, Copaxone, Brabio and Clift. Number 68, interferon beta with Avanix, betaferron, Extavia, Plagridi and Rebif. Number 70, teriflunomide, Obagio. Number 72, natalizumab with Tysabri and Chiruko for active relapsing remitting MS. Number 74, S1P modulators with fingolimod gelenia, oxanimod ceposia, ponesimod ponvari, siponimod mazent for active RRMS and SPMS. And number 76, alemtuzumab with Lemtrada and Campus for highly active multiple sclerosis. By the way, next time I will talk with Professor Dr. Natalia Shako about how your gut microbiome could influence multiple sclerosis. I think it's a very interesting topic and it gives you the chance to do something on your own. So please tune in again and recommend the podcast to people who might be interested in the content and rate it wherever you're listening to it. And of course, if you have some recommendations of possible topics, please write me at nele@ms-perspektive.com. And remember, stay as healthy as possible and positive as possible. And see you next time. Bye. Thank you for listening today. I hope you found it helpful. You may also be interested in the previously published episodes and posts, which you can find at ms-perspektive.com/podcast. Perspective with a K. You can also get a free PDF with 11 tips for your positive impact on MS at ms-perspektive.com/newsletter. If you'd like to get in touch, you can reach me at nele@ms-perspektive.com or on social media. See you next time.